Hello and welcome to our overview of Lesson 5 of the CCVR course. Today we're focusing on another critical aspect of vestibular medicine, which is central vestibular disorders and medical management. So just as with peripheral vestibular disorders, an accurate diagnosis is the cornerstone of effective treatment, and understanding the pathophysiology and optimal medical management of vestibular-related disorders is so key to improving and optimizing patient outcomes. Now, central vestibular disorders can create even more challenges. One of the primary challenges is to identify the cause of central disorders to all the added associated pathways. So as it's shown on this slide, we think not only of the primary processor of the vestibular system, which is the brainstem, and the adaptive processor is the cerebellum, but also those shared pathways with the cortex and the thalamus. So involvement in any of these areas can result in notable balance, visual spatial processing dysfunction, or what we call sensory reweighting dysfunction. And as mentioned previously, imaging can be normal even with central disorders. So think about Parkinson's disease. We don't diagnose that by imaging. And there are several types of spinal cerebellar atrophy that may not show up in imaging. There are some known distinct patterns associated with central nystagmus. However, clinicians must be aware that central nystagmus can mimic peripheral nystagmus, and some patients can have both central and peripheral nystagmus. This can happen, for example, if a patient has an acoustic neuroma on the peripheral vestibular nerve, but the size of it is also impacting central structures. So some patterns in central nystagmus, it may not change with fixation like we talked about in peripheral, but that's not an always. It may present as a pendular or a square wave jerk, an upbeating, a downbeating, a purely torsional, or as a gaze-evoked nystagmus. So there are several different types of central associated nystagmus. And like I said, it can coexist with peripheral vestibular nystagmus as well as symptoms. An added value in central vestibular disorders is taking into consideration all the other central tests that you can do at bedside, which is look at tone, coordination, ocular motor, and even cognition. Now, the acute onset of vertigo is poorly understood in the emergency department, yet that's where most people would go to be evaluated, as they should, because our big concern is someone having a stroke. So researchers have shown that the HINTS Plus exam, which is head impulse, nystagmus, and test of skew, yields a high sensitivity and specificity to identify peripheral versus central disorders. Yet it is done less than 10% of the time in the ED. It is most reliable in the first 24 to 72 hours of the onset of acute vertigo. And if you're in the outpatient setting, by the time someone comes to see you, that test is not as valuable as it is in the acute phases. There are also known neurotologic disorders that are common yet poorly understood, such as labyrinthine concussion, vestibular migraine, persistent postural perceptual dizziness, or 3PD. It can also be more difficult to predict outcomes in central disorders, especially functional neurological disorders and progressive central disorders. So in medical management, as with peripheral vestibular disorders, medications can be used to improve quality of life, although they may hinder recovery. This includes medications to reduce dizziness and even nystagmus. A non-pharmaceutical option for those with persisting central nystagmus can try prism glasses to help reduce their symptoms. And as we discussed in peripheral vestibular disorders, there's an important role in complementary therapies. So this is in addition to medical and rehabilitative treatments. They play a significant role in managing both peripheral and central vestibular disorders. And things like cognitive behavioral therapy, talk therapy can also be important when patients are facing neurological disorders. And just to summarize, proper medical management of vestibular-related disorders hinges on that accurate diagnosis and a comprehensive understanding of the pathophysiology. We've talked about the challenges in obtaining an accurate diagnosis. In the CCVR course, we'll take a deep dive in both pharmaceutical and non-pharmaceutical options in managing patients. And those complementary therapies like cognitive behavioral therapy, talk therapy, can play a significant role in any diagnosis, but we often see a greater need of that when there's a neurological disorder, especially something progressive or a disorder poorly understood. So thank you for joining me in this overview of Lesson 5. I hope you can join me in the next video on Lesson 6. This is where we get to talk about BPPV and look at all the different types all the different maneuvers and bring you up to speed on more current maneuvers that just seem to be increasing. Thanks so much.